Hey, everybody, it's Teepa, and I'm here with Barbara Grabher, and we're going to be talking PET scans with somebody who's really, really knowledgeable about PET scans. Not so much me. I understand the basics of them because I've been around a lot of folks looking at and curious about PET scans, but Barbara, she's the person you want to know about if you're going to go get one or you're considering getting one for yourself or someone else. So Barbara, go ahead and give us a little bit of the background on yourself. Who are you and what do you do for a living?
Thank you, Teepa. Thank you for inviting me and my company, Life Molecular Imaging, for speaking with you and your group today. My name is Barbara Grabher. I am a clinical application specialist for Life Molecular Imaging. I was trained as a nuclear medicine technologist, and I've been in the field actually 39 years, almost 40 years. So it feels weird to say that. And I've been doing application support for about 18 years, all in the nuclear medicine arena. So basically what I do for people now in my current role is my sales reps and my medical science liaisons that I work with our company sell the products and talk to physicians and talk to technologists about the nuclear medicine products that our company sells. And then I go into the hospitals and clinics and teach the technologist how to do a really good scan. So how to make sure their patient is set up properly on the table, how to use the radioactive tracer that we inject and things like that. So
wow. So Barbara has a really critical job. Her job is to make sure everybody who's using this technology uses it well and effectively so that when you get one of these scans, you end up getting a good scan. So you don't go through all this and then find out, oh, shoot, I wish I'd done that. That's not what you want to hear after you've been through one of these scans is, oh gosh, man, I really messed that up. Or you don't even hear that. You just hear, well, that scan didn't work for you. It's like, so Barbara's one of those people who really, her expertise is in not only understanding what is going on, but how to help the person who's getting the scan get a good scan and how to make sure that everybody understands what they're getting into and how it's going to happen when it's happening. So there's less of a fear factor and more of an appreciation of what is going to happen before you get there, so that you know what you're getting into. And surprises are the thing that people don't like when they're living with dementia, whether you're a family member, or you're the person, or you're a professional. When you get surprised with stuff, you tend to have an immediate knee-jerk reaction, which is not what you want when you're in a complex piece of equipment and stuff is going on. So Barbara, go ahead and share with us a little bit this imaging thing, this PET imaging particularly, which is what we're talking about today, is these PET scans.
Sure. I have some slides, so I'll go ahead and share my screen here. Okay, so we're going to talk a little bit about a PET scan. So what does PET stand for? What does brain PET stand for?
Hang on for 1 second, because what I skipped is that decision that this would be a good thing. But we're going to assume that part a little bit because we really want to dig into Barbara's expertise here and help people understand this thing about a PET scan. And she's going to do a great job on that. But I just realized as you were like part 2, people are going to go, what about part 1? And it's like, that's how do you get to this place where you're thinking about, I need a PET scan, or we might consider a PET scan.
Yes.
And we're not talking about that today. We're talking about this real deal. Like, okay, so we're talking about a PET scan. What is that?
Yep. So we're talking about the PET scan itself. So what do you need to do and what is it? And a whole bunch of information that hopefully once we go through all this, you'll have a better understanding of what a PET brain scan is, how it gets acquired, and how it's important for you as the patient living with Alzheimer's and getting this scan done. What are some of the things you have to do to make sure we can get the best scan that we can get? So what is a PET scan? What does PET stand for? PET stands for positron emission tomography. Okay. It's a type of scan performed in nuclear medicine on a special scanner. And what happens is we inject the radioactive tracer into the patient, and then we scan different organs in the body. So we have all kinds of organs that we can image in nuclear medicine. PET is just one way we do that. Okay. We inject and we can look at the brain. We can inject a PET tracer and look at the whole body. But for us and what we do, we're going to talk about PET brain imaging. And I like this cute little picture here. So these are PETs on top of and laying on a PET scanner, but PET stands for positron emission tomography. Okay.
Oh, we would much rather it stand for all those cute puppy dogs, but that's
I know. I love the picture. That's why I left it in there.
Yeah. Yep. So when you say, tracer, radioactive tracer, everybody's brain probably goes, but it's something that has been developed, and you'll talk a little more about it. But what we're really able to do then is look inside the brain where things are going and what's happening. So you're going to talk more about that. And so it's really important. That piece of equipment you just saw is part of the puzzle, but here's the big piece.
Yeah. So there's basically two different types of PET brain scans we can do right now. One of those is called an FDG brain scan. And when we do an FDG brain scan, we're basically looking at metabolism within the body, and our brain metabolizes and gets energy from sugar. So our body and our brain can metabolize either sugar for energy or fat for. So in the brain, we metabolize sugar. So basically, we're taking a little molecule of sugar, we're attaching a radioactive tracer to it, it gets injected, and then we look at the brain and see how the tracer is being picked up or not picked up. So we can have increased uptake of the FDG tracer, okay? And that's called hypermetabolism. Or we can have decreased uptake of the tracer, and that's called hypometabolism. And depending on the different patterns of the hypometabolism, that can tell the physician, your dementia, your neurologist, what type of dementia you might have. So and here you can see on the little chart, we can have Alzheimer's disease, and that hypometabolism, there'll be a special pattern that they look for that. You could have dementia with Lewy bodies, and that kind of affects the back part of the brain. So here in this picture, whoops, sorry about that. Here in this picture, you can see with Lewy body dementia, it's in the back of the brain where the occipital lobe is and where vision happens and things like that. So different patterns are going to tell the neurologist different things. Frontal temporal dementia, that's more in the front of the brain. And then two kind of rare diseases, cortical basal degeneration, and then posterior cerebral atrophy also have a different hypometabolism. And this tells the doctor a lot when he's trying to do patient management and things like that, because every disease is treated a little bit differently. Some of them might have similar symptoms, but the doctor really has to know what he's dealing with before he can accurately treat the patient living with Alzheimer's. That you might have a cognitive impairment, but that cognitive impairment can be treated very differently, whether it's Alzheimer's or whether it's frontal temporal dementia or Lewy body dementia. So FDG PET imaging is important. And then we also have amyloid imaging, which we'll talk about in a few minutes, but this just happens to be the FDG portion of it.
Nice. So Barbara just put together some really good pieces of data. So with Lewy body, for example, one of the things we'll often see is a busy occipital area, but although it's busy, it's not burning sugar well. So one of its things is it causes you to see things that aren't actually accurately there. And people tend to call those visual hallucinations. But what they are is I see animals, children, people, my brain is doing that. Sometimes we will also see some shifts in activity. We might see, and Barbara, I know here you're showing hypometabolism. Mm-hmm. I'm wondering if hypermetabolism compared to a normal brain would also be indicative of, wow, what's going on here? That's a lot of metabolism to be going on in that little chunk of brain. I wouldn't expect that much.
That's a great question. I'm only a technologist, not a physician, but I know when we have our physician speaker coming, that might be a great question to ask her. For me, I know that the hypometabolism is where the brain's not functioning properly. And then we get these different patterns of tracer. And then the doctor can tell what kind of disease or cause of dementia might be going on based on that pattern. So we should write that question down for our other guest speaker.
For our other speaker. But what's really cool about this is it helps focus the doctor's attention, and it helps us potentially as partners in care take a look at what's going on and recognize, oh, that's not disinterest in not trying. It really is, look, there's not as much chemistry going on in that part of the brain.
Exactly.
And so we can maybe start the art of letting go of some expectations and shifting our expectations based on this data. Because sometimes, truly, human beings, when you see something, your brain goes, oh, so that's like real, huh? And it's like, yeah, that's like real, huh? So it makes it easier for us to let go of this idea that the person isn't trying or that they're doing this on purpose. And I think these kind of patterns are so essential when you're sort of frustrated with what's happening in relationships, in life, in how the person is doing. And the right medications can make a difference. And again, we'll bring that up when we talk to the doc, but we may not want the same medicines on board if we've got one condition versus another, because our brain should tell us, ooh, that's not what's actually happening here. We got something else cooking. Cool. Thanks, Barbara. Okay, so now let's talk about the other kind of PET scanning that can happen.
Sure. So again, we have our FDG scan here. And this kind of just shows us an MRI that looks at structure compared to our FDG scan here in the middle. And then those little patterns of hypometabolism that we just talked about. So this is just another example of what the physicians will look at, or what the nuclear medicine physicians will read, and then the report that the neurologist gets. So sometimes they'll look at MRI, sometimes they'll look at FDG PET. And then we also have the amyloid imaging, which we're going to talk about here in a few minutes. So the second type of PET brain scan is an amyloid PET brain scan. It looks for amyloid plaque in the brain. Okay. The scans that they get categorized kind of in two buckets. Either your scan is going to be beta amyloid positive, which means you have amyloid plaque in the brain, or amyloid plaque negative. Okay. And we look at 4 different regions of the brain. Okay. We look at the lateral temporal lobe. So if we start down here, we look at the lateral temporal lobe. The way I remember where that area of the brain is, it's kind of near the ear. So if you remember lateral temporal, the E in temporal, that's kind of near your ear. Okay. Then we look up into the frontal lobe, and that's kind of simple, just the front of the brain. So frontal lobe. And then the next region we look at is the posterior cingulate precuneus. Okay. And then the parietal lobe is a little bit higher in the brain. What we do is, in a negative pattern of tracer uptake, we want to see these white matter tracks. And then right next to it, there's a little bit of gray activity uptake here. So we want to differentiate the white matter tracks from the gray matter in each of these sections of the brain. Okay. In the frontal lobe here, the doctor, when he reads these scans, he's looking for these little starfish. As patients start to accumulate amyloid plaque in the brain, that gray matter starts to pick up the tracer activity, and that could be a sign that you could have Alzheimer's dementia. Okay. Now, as we age, we also get some plaques, but the doctor's going to put everything all together. He's going to put the scan results of whether your scan is amyloid positive or amyloid negative. He's going to take your MRIs, your CAT scan, your clinical symptoms, put it all together, and then decide, well, based on everything we have here, I really do think you are living with Alzheimer's disease or something like that. So as the scans become positive, you can see from the negative, what I call all the little nooks and crannies of the gray matter start to fill in, and the edges of the scans get really smooth. So on the left side here, we have the negative pattern, and on the right side of these images, we have a positive pattern, and that tells the doctor what he needs to know so he can treat the patient accurately.
Yeah.
With the right medications and things like that.
Yeah. So Barbara, this is the one time that you don't want to be positive. Let's be honest. This is the one time you'd rather be negative. And in the work where we usually do a lot of talking, we talk about you have gray matter and you have white matter. And the white matter is wiring. And the gray matter is storage units. And when you get a lot of white in your storage units, in this case, it's like, we're starting to get buildup of goop in those storage areas. And that's not great because it makes it hard to get things in and out of that storage area if it's all gooped up, essentially.
Yeah.
So what we're looking for is low amounts of that white pattern in the gray matter. We expect some of it to be in the white matter. I mean, that's actually not that abnormal at all. We would expect that to be like that. Yeah. And so what's cool is sort of how this technique of attaching a tracer, and this we're attaching it to that beta amyloid plaque stuff that allows us to look and see where's it building itself up and where is it occurring. But we all have a little beta amyloid. I mean, everybody goes around with it. As we get older, we get a little bit more. But we think there's some kind of tipping point when you get from being, you got some, and it's not necessarily a bad thing. It's just what happens, to, this is a cascade event. This is something that seems to be, this is not the direction we want to see it happening. And early on, it can be harder to notice this, particularly without this kind of scan. You wouldn't be able to see it in behavior yet necessarily all the time. You wouldn't necessarily be able to see it in how somebody's doing on a regular day. But when they get stressed, that's maybe when you see the changes in ability. So this gives us a preview, if you would, of where there might be issues that allow then for better care planning and better life planning and better engagement where it makes sense. And it puts an identifier on what otherwise can be really stressful.
Exactly. It helps explain what's going on or why it's going on, which even if it was a positive scan, at least you have an answer, you have an accurate answer, and then the doctor can move forward with the proper treatment. Because if you're on one treatment and he thinks he's treating one thing, but he's really not, then it's not helping. So these scans are really important that help guide patient management. Yeah.
And I noticed, Barbara, you said the word Alzheimer's specifically on this. So I think if I remember correctly, when you have a frontal temporal dementia, this would look different. I mean, these scans would look different because how beta amyloid is involved in FTD is pretty different than how it's involved in Alzheimer's, which is really also different than how it's involved in early Lewy body. So, some of those things can also be helpful, as they say, to differentiate. But we'll talk more about the next time, but it would look different. And I think that's helpful for people to appreciate. It's not like this is dementia, this is not dementia. This is pretty much associated with some form of Alzheimer's most of the time when we see these positive scans. Not even vascular. Vascular would look different, yes?
So vascular dementia is going to be a blood flow thing. So my scan's going to look, this amyloid scan's going to look totally different, but the cognitive component of the symptom is still going to be there. And then the doctor has to say, okay, what is this? So he may start with an amyloid scan or an FDG PET scan and say, okay, here's the hypometabolism pattern, or here's positive or negative for amyloid plaque. And then he may or may not have an answer. And then he has to keep going, to find that accurate diagnosis to accurately treat and proper patient management.
Yeah.
So,
and I know that
really
one thing, and I know that one thing that often comes up is, well, why bother? And it's like you've said that, because it can make a big difference. And do I want to wait till somebody's in the very late state of a dementia to start this? It's like, now that makes less sense. But starting it when symptoms first kick in, or I don't even know for sure what I'm looking at as a dementia, that's when it really could make a big difference in figuring out what to do and how to do it. And I think that's one of the messages is early identification, even though you're hoping against hope it isn't, can really inform how things move forward from there and decisions to make. Yeah. So thanks, Barbara.
Decisions to make.
Yeah.
The person living with Alzheimer's early stages can help with their own management. They can help make those decisions and things like that. They can maybe get into some kind of clinical trial that's ongoing now. There's a ton of stuff out there that you can get involved in from a clinical perspective. So the more that your doctor knows, the better he can treat the person living with Alzheimer's.
Yeah, cool. All right, I'll let you keep going now, because those were just things I know that people are curious about.
Yeah. So what's the difference between a PET brain and an MRI scan? Well, or a CT scan. So PET looks for function, how the brain picks up tracer activity, whether it picks it up too much, hypermetabolism, doesn't pick it up at all, hypometabolism, right? MRI looks at the structure of the brain. And we see that here in examples A and B here at the bottom. It looks at the structure. So now in an MRI here, image B, if you can see my arrow, all that is the white matter of the brain, okay? And then the gray matter is sitting right next to it. And the interesting thing that I always find fascinating is that gray matter is only 2 to 4 millimeters thick in an average normal person in a normal brain. And when you have atrophy or some kind of dementia, that's where that gray matter is picking up that amyloid tracer here. And it's only 2 to 4 millimeters thick. So if we have motion in our scan, if the brain is atrophied, it's shrunken down, it makes it that much harder for the doctor to look at the images and accurately decide what's going on in the brain. So MRI, again, looks for structure. They look for the white matter and gray matter. These dark areas here in the middle, those are the ventricles of the brain. Sometimes if they're enlarged, things can be happening there as well. The doctor needs to know that. People with metal objects in their body, they can't have an MRI, right? So that can be challenging if someone has some kind of metal, a pacemaker, something like that. So an MRI may or may not be available for you to get. It has very good image quality, but MRI is an expensive test. It's a little bit more expensive than a CAT scan. Here we see a CAT scan. CAT scan also looks at structure of the brain. So here in the top row, we can kind of see that white matter again, right? And then right next to it is the gray matter. So the doctor, when he looks at that, he's looking at the structure of the brain, kind of what size is it? Has it shrunken down and those kinds of things. Those little black spaces again, those are the ventricles. We look at the doctor can look at the brain in a whole bunch of different sections from the top to the bottom, which is this picture here. The middle picture is from side to side. And then the picture here on the right is from the front of the brain to the back of the brain. So there's all different ways the doctor can look at the images to find out what's going on. And then this middle row here is a nuclear medicine scan, okay? And then what they can do with technology and software on the scanners now, we can fuse those two scans together. And that's what this bottom picture shows. So it takes the MRI or the CAT scan and then fuses them with the nuclear medicine scan. And the doctor can kind of see an overlay of the two. And that helps him as well to pinpoint different areas of the brain that could be effective. CT is a little quicker than an MRI. MRIs are that machines that made a loud banging noise. It's kind of scary. I've had an MRI of my brain, and they put that coil around your head, and I get a little claustrophobic doing that one. But different scanners that we do different things. So some are loud, some aren't as loud. The nuclear medicine scanners, the PET scanners, they're not loud like an MRI. There's a big circle, but we'll talk about the scanning itself here in a few minutes. And then CT is obviously less expensive than an MRI.
And classically with the CT, that's when people are looking for those enlarged ventricles. They're looking for masses. They're looking for parts of the brain that have died due to strokes or those little blockages or aneurysms, those kind of things. So they're looking for physical changes in the brain structure. And so that's when you do that CAT scanning or that CT scanning, that's the kind of thing that's what you're looking for. These are, these other images allow us to look at chemistry and structure. And that, when we're talking about dementia, is often something that's going to give us more in-depth data that we're looking for, especially early on, and even in the middle of the condition. If something's changing, we want to know what's going on here. This is not what I would have anticipated given what I thought we had going on. So, or this is exactly what I would have anticipated, or, oh, wow, this is something new. So it gives people that opportunity to have an initial idea and realize dementia is a process that takes place over time. And so recognizing it may be time for another scan, because what we're seeing now is honestly not what we would have anticipated. And that's also, I think, sometimes how and when. So, you're going to talk about all this. Look at you. Go for it, Barbara.
So why do we do PET brain scans? We can do them for many reasons. We can look at glucose metabolism, the FDG scan that we talked about, because that's important. If our brain is not metabolizing sugar, our brain does a lot of different things, listening, seeing, functioning, putting things together, reasoning. So our brain is always metabolizing sugar. And if someone's brain is not metabolizing sugar the right way, that there could be something going on that the doctor needs to know about. We can look for amyloid plaque in the brain that we just talked about with our amyloid scans. And again, they can be amyloid positive or amyloid negative. Okay. And each of those amyloid positive and amyloid negative will get treated very differently. Even though you have a cognitive impairment, it still can get treated very differently depending on your amyloid status, because the different diseases get treated very differently, but they have similar symptoms. So the doctor might go down one road and think it's one thing, and it's not. So the scans become very important. We can look at other diseases or pathologies of the brain with other tracers that are not FDA approved yet, but are in research. So if you end up getting into some kind of clinical trial that may be using a research tracer that may help. And then we can also look for metastatic disease of the brain from cancer that may have spread from breast cancer, prostate cancer, lung cancer that may have gone to the brain. And we look for different patterns of tracer uptake for that too. So there's a lot of different reasons why we would do scans, but they're important because they help the doctor go down the right path to treat and care for his patients. So
nice job. Yeah. And so this includes, I think one of the things that's in research is synuclein work. So looking at the tracers for synuclein, which is associated more with Lewy body disease and the Parkinson's related stuff. Yeah. And so that's an area of development. And, hopefully soon will become something that is used in practice, just as we have some of the others.
Exactly. And tau is another one.
Yeah, tau is one that we're starting to recognize. Wow, big difference for FTDs and some of the dementias that, you don't want to be using something that's going to affect beta amyloid if that's not your primary, because that can result in some significant issues for folks. So, we're on the front edge of a lot, but I think what we're saying is we're further than many people recognize and realize. And that's because for the longest time, many people had, well, like if it walks like a duck and quacks like a duck, why not just label it a duck and be done with it? And it's like, well, we are learning a lot more about different dementias. That's no longer an okay thing to do. Just slap a label on when it may be totally inaccurate about what it is that would be helpful to someone. There is some more differential, not just diagnoses, but then management that we can start to see. And that's where we are. So,
yeah, I mean, nuclear medicine, molecular imaging play a big role in helping physicians diagnose patients because before these scans were available, it was the doctor's visual assessment of his patient, listening to symptoms, hearing things, how they're going on with their daily life, listening to their caregivers and what they're telling them to try to make a decision. And it's, we're all not 100% accurate and right all the time. And these scans definitely help.
The best we had were CAT scans or CT scans previously before this kind of work. That's all we had, or autopsy. We could wait for an autopsy. That was about it.
Yeah, but here now with these scans, we can help manage patient care sooner, where they can function and have as normal of a life as they can and what they can do.
We can start working on our new normal. Cool.
Yes.
Hi, I'm Teepa Snow, and you just found our YouTube channel and watched one of our videos. I'm the owner and founder of Positive Approach to Care. Thanks for watching. And if you liked, if you have a comment about, or you would, please share it with people you know. Oh, and if you haven't yet done it, consider subscribing. We'll let you know when the next new video comes out. And you might want to visit our website, www.teepasnow.com, where you'll find other resources as well. See you there.